Good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's webinar on Healthcare Transitions, Lessons from the Field. Now, before we begin today's presentation, there are just a few logistical items that I'd like to review. For optimal visual and audio experience, these webinars are best accessed in the Chrome browser. So if at any point you encounter any audio issues, we do recommend logging back in using Chrome. If you continue to experience any issues, please dial in using the phone number that was provided in your confirmation email. Now, for those of you who have never joined us on this webinar platform before, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat can be used to pose your questions to our speaker. If you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenter to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, registration is currently open for our next webinar, which is our Brain Death Declaration Series from a Nursing Perspective. That's coming your way on July 16th at 2 p.m. Eastern. Registration is also open for our upcoming webinar on the Littlest Donors, honoring the gift of life through neonatal donation. Be sure to join us for that on July 23rd at 2 p.m. Eastern. You can register for all of these webinars and more on our website at organdonationalliance.org. Following the completion of today's webinar, you will all be eligible to claim CE credits for your participation. Please note we are offering 1 SETC credit and 1 nursing contact hour. If you're listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. There is a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 days to claim your credits, and for SETC, you have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Paul Myung, Senior Administrative Director at Massachusetts General Hospital. Paul, thank you so much for joining us today. At this point, I'd really like to turn it over to you to introduce our speaker.
Thank you, Deanna. It's my distinct honor and pleasure to be introducing Dr. Maria Díaz-González de Ferris, and to also thank her for opening up her time today to share her expertise on this important topic of care transitions in the pediatric to adult transplant recipient patient population. Dr. Maria Díaz-González de Ferris is also a pediatric nephrologist, professor of pediatrics, and the founding director of the University of North Carolina Healthcare Transition Program. She is also the founder and co-director of the International Healthcare Transition Research Consortium and the International Pediatric Renal Fellows Program. She received her medical degree from the Universidad Nacional Autónoma de Mexico, her master and PhD degrees from the University of Texas Houston School of Public Health, and has been in practice for more than 30 years. Outside of work, she likes to garden, sing and dance, and bake because she's also a professional cake decorator. So without further ado, please join me in welcoming Dr. Maria Díaz-González de Ferris.
Thank you, Dr. Myung, and thanks, Deanna, for your help. Welcome, everyone. I am going to try to get you excited about this field of healthcare transition, and my goal is to get you more excited about adolescents and young adults. Sometimes they're the headache patients. I call myself an adolescent nephrologist, and I think that these are the most rewarding and challenging patients. Today, we are going to talk about the experience we've gathered for the last 13 years. We're going to talk about our publications, the lessons from the field. And the latter part of the presentation will focus on some of the tools that we are testing or using, and hopes that everybody feels comfortable contacting us and using these tools that are free of charge, or tools that are available in the website depicted below, www.med.unc.edu/transition. And welcome for this presentation. I would be remiss if I did not acknowledge those who have helped us get this far. And our program has been serving patients who are 12 to 29 years of age to enhance, teach, and promote self-management and transition readiness. We have to primarily thank our patients, families, and volunteers. Thanks to our work over the last 13 years, we have produced over 70 publications in English and in Spanish. We have partners across the U.S., across the world. We have a few new partners which are coming online now. We have received funding from several sources, Renal Research Institute, the CDC, HRSA, NIH, and of course the UNC system and the STARx Interdisciplinary Research Team. These are our gatherings weekly. Yes, we do like to eat, but we like to play more than eating. And all these fantastic team members are enthusiastic and ready to help you if you would like. Our program started in 2006, and I'd like to point out that we are now official teenagers in terms of definition. It's our 13th year, started in May this year. And we developed and validate tools to measure healthcare transition. We serve several conditions, including solid organ transplantation, chronic kidney disease, IBD, cystic fibrosis, lupus, diabetes, mellitus, developmental disabilities, sickle cell disease, neurological, mood, and behavior disorders. So now that I introduced you quickly to our program, let's talk about why this field is important. It is important because people are surviving. Patients who have pediatric onset conditions who used to die in the past are now making it to their 40s and 50 years of age. Look at, for example, the sickle cell disease patients in the 70s. Their 10-year survival was 15 years. And in the 2000s, they make it to 40, 50 years of age. Look at cystic fibrosis. In the 50s, there was very little survival, and in the 2000s, they can make it to their 40 years of age. What about our patients? I'm a nephrologist, so I'm sorry to be nephrocentric, but what about our patients with adolescent onset end-stage kidney disease? When I started in this field, I partnered with Paul Eggers and Paul Kimmel and Debbie Gibson, and we looked at the 10-year survival on adolescent patients who had end-stage kidney disease in the U.S. And I'd like to point out to you the patients that were in the cohort diagnosed in the 1970s, the red line, their 10-year survival at the time was 70%, whereas if you were diagnosed after 1993, your 10-year survival was 85%. So it's greater survival than the adult patients who develop end-stage kidney disease. So the question is, how do we help patients get from this age, 12, 13 years of age, to this age successfully and managing their disease no longer directed by their parents? So healthcare transition, a definition for everyone, is a process that involves adolescents and emerging adults, new term that is being used, their parents and providers. What happens if we don't prepare patients to a transition? Well, transfer adults without preparation have bad outcomes. It's been published in many countries and several conditions, and I could show you more conditions, but they all show the same thing. When they go unprepared to the adult world, they could lose their transplant in all these three countries. If you have diabetes, you have higher hemoglobin A1C. If you have rheumatoid arthritis, you can have more disease activity. And more can be shown on any other condition. I just picked a few of them. Let's talk about what happens if you're growing up in a family and you have a chronic condition. You probably are more likely to see your parents have greater marital distress, greater number of parents divorced, and greater number of patients are raised on a single-parent household. But we do know that if you have a single-parent household, there is greater level of stress for the parents with all the things that they have to keep up with. This is no surprise to us providers in the field. We also know that chronic pediatric onset conditions have a greater impact in the household. There is greater emotional, physical, and financial stresses. And the forgotten kids, the siblings, have also greater distress. There are very few studies that focus on the healthy siblings, but we've noticed that the siblings have more aggressive behavior, and they miss out on activities and support because the parents are focused a little bit more on the children with chronic conditions. I'm going to shift gears a little bit, and I'm going to talk about the healthy brain. And this is one of my favorite slides to talk about in presentations like this, because it gives you perspective about our brain. So on the left side are pictures of 5-year-old brains And on the right side, these are pictures of more mature, older brains. This study was a 10-year longitudinal study funded by the NIH, and it looked at brains using static MRI images. And they did a longitudinal follow-up. You can see in this picture that there's more blue appearing as you get older. So your brain is maturing, there are more connections. And the last part that matures is the frontal part of your brain. These are typical brains. These are not brains with any health condition. These are typical brains. But the most important thing that I want you to take from this slide is that the frontal part, where you have impulse control, and abstract thinking, the frontal part is really developed when you're in your mid-20s. So really not even when they're in the pediatric age group are ready to go. This was your brain, your healthy brain. This is your brain in CKD. This is a study that had been conducted at UNC by Debbie Gibson and Dr. Hooper, and as partnered with folks in Canada. Basically, this study looked at functional MRI. The previous study looked at static MRI. And in patients who were controls, and they were asked to do tasks, look how many lights, look how many things are lighting up as they're doing tasks. Look at the patients with chronic kidney disease and end-stage kidney disease. It's very different. It's almost like being in the dark. So these patients that come to your adult practices not only have an immature brain right there, but they also have a brain that has a lot of affection because of the chronic kidney disease. The other thing that we have to deal with, unlike adults with CKD or end-stage kidney disease, pediatric patients with chronic and end-stage kidney disease have different diagnoses depending on the age. So if you were diagnosed at a younger age, you're most likely going to have what we call non-glomerular diseases, such as congenital anomalies of the kidney and urinary tract and birth defects of the kidneys. Whereas if you're an adolescent, the cause of CKD is less likely to be a congenital anomaly in that sense, but more so glomerular diseases appear. These kinds of patients, the younger age patients, are very different patients and families compared to these patients, the older diagnosis patients who were diagnosed at an older age, because they have had the opportunity to have a typical childhood, have socialization, and opportunities to form partnerships and relationships with peers. Whereas the younger patients who have congenital anomalies of the kidney and urinary tract are at greater risk to have enuresis, difficulty making friends. Sometimes they have dysmorphic features, being bullied. So it's a whole different set of patients and families. And we're trying to understand how different they transition. In our program, we try to start our transition preparation at age 12 and 14. But when does it finish? Well, we graduate them, and we have a graduation visit usually 1 year after they have completed in college or when they start to work. We don't like to hand them out to the adult-focused patients based on you're 18, you're ready to go. And we also don't do it when they are going to college because it's too many changes. They are leaving their house, they're going to college, they're changing doctors. So we like to keep them for another year. After the first year of college, then we send them out to the adult world, and we try to do the handoff. We try to have a clinic on the day when the adult provider, in this case, is ready to receive this young man who's graduating with flying colors. No drama. We're not crying. We're not sad. The patient is not upset that they're leaving us, and their patients are being welcomed by the adult providers. Okay. I've given you an introduction briefly as to what it means to do transition and why this is important. Now, I would like to share some of the lessons from the field and some of the publications that we have done. What I'm going to quote is based on the tools that we have invented or developed in our institution, and those tools are free for everyone to use at this particular website. I'd like to tell you about one thing that we learned while working with adolescents. I was trying to understand how are we going to talk to adolescents and why is it different talking to adolescents compared to their parents. But I also wanted to learn how the adolescents prefer to learn about their health conditions. So we asked a few hundred adolescents with many chronic conditions at a Victory Junction camp, which is one of our research partners in North Carolina, who receives campers 6 to 16 years of age from across the country, mostly from the southeastern United States. And I asked these adolescents, how do you like to learn about your health condition? I gave them these choices. Reading information in a handout or brochure, we thought was not very popular. We had our biases. Looking up information on the internet, because we thought adolescents were very much into technology. Asking the doctors or nurses, asking my parents, and asking other kids about their health condition. Since I cannot poll the delegation, I cannot poll my audience, I can almost tell you that most everyone will pick the wrong answer because we certainly picked it. To our surprise, and we published this, most patients prefer to learn about their health condition from their parent. Houston, we have a problem, right? Because we don't know, or we really have no idea how much the parents know about their health condition. One thing we also learned in that publication, that if the adolescents prefer to learn from the parent, they are better adherent to treatment. They have better compliance. Oh, I'm using the wrong term, better adherence. Whereas if they prefer to learn from the providers, they know more about their disease. So it's interesting. So we were concerned because we learned that the adolescents prefer to learn from the parents. And so what we did, we developed a couple of tools. I'm going to talk about one of them right now, the Transition Index. The word transition has 10 letters, 10 areas that focuses on measuring self-management and transition readiness. We have the youth version and the parent version. And so we wanted to know if the parent score was close or predicted the patient's score. So it is. They predict one another. So if the parent doesn't know, the patient doesn't know. So in the middle of our development, in about year 6 or 7 of our work, then we said we learned this, and we decided that we also have to focus on educating our patient parents. In the first 6 years of our existence, we focused in developing measuring tools that are somewhat valid. No tool is valid. There are a few tools in the market that are being used. No tools, not even ours, not even with the many publications we have, can be claimed to be valid. But we're pretty close to having decent tools. So we have the Transition Index, where providers ask questions and the providers verify their knowledge. We have a parent version and an adolescent and young adult version, which can be given in the pediatric setting, on the adult focus setting. And I don't have time this presentation to go over these tools, but I want to tell you that if I was going to use a tool and I want the more valid one, I would focus on the Transition Index, because a health provider would ask the patient, tell me the name of your disease, your type of illness. Tell me your prescription, Rx. Tell me your nutrition, your diet. If the patients don't know the answer, they don't get the credit. So that's why I like this tool better. This other one is self-administered when you don't have the manpower, and it's still, it's complementary of the Transition Index. But the STARx Questionnaire is totally self-administered, total self-report. So we have to believe their word. So there are good things about a self-administered tool, meaning you don't need to have the manpower, but there are also bad things because they can tell you stories. No, doctor, I don't do drugs. No, doctor, I don't have sex. I'm an adolescent and I don't do any of those, right? Anyway, so for the STARx Questionnaire, we also have a pediatric and an adult-focused version. Those were our measurement tools. We are now working on intervention tools, and I'll mention some of those to you. The STAR Passport, Kidnopedia, now known as the Kidney Guru. And we have our apps, mobile apps, Planet K and Planet T1 Diabetes. so type 1 diabetes. In this presentation, I will not be able to focus a lot of this on these results, but I will tell you a little bit about them. So how do we measure healthcare transition? This is Christy Bickford, the person that helped us get started. This is our coordinator. She was with our program for about 12 years now. Her duties have changed, but she would visit with the patient, and she's giving the patient what he's holding is a transition passport, and I'll show you what that looks like. Sorry. Okay, so I talked about the self-administered STARx questionnaire. It has 18 questions. It measures 3 areas: how frequently they're engaged in self-management, how much do they know about their condition, and how difficult will it be for them to move to the adult services. This is what the questions look like. They're web-based. It's used on many conditions, and again, it focuses on these 3 domains: self-activation, self-efficacy, and self-direction. For example, how often do you make an effort to understand what your doctor told you? Never, almost never, sometimes, almost always, and always. So we use Likert scales, and then we measure that. The transition index, which to me is a little bit more reliable, talks about the 10 areas I discussed: type of illness, medications, adherence, trade or school. We had our bias as to what a 12 and 14-year-old could manage learning, what could a 15 and 18-year-old could learn, and what would an 18-year-old need to know or can handle. Those were our biases. And let me show you some of the data that we've learned. We call somebody ready to transition if they have at least 70%, 75% of the skills. So this picture depicts what we have learned on the field. As I mentioned, we had our biases. We thought that a 12 and 14-year-old could manage understanding prescriptions, adherence, and type of illness. Let's see what the data showed us. So we looked at longitudinal data. So this is observations of over 10 years on 862 patients across the UNC system, and 12 to 29-year-old patients were enrolled in this study. And this data comes from that cohort. We just published it in 2017. We learned that the 12 to 14 years of age patients can learn and understand about the importance of adherence and securing ongoing support when they're in the adult services. 15-year-olds can manage very important tasks such as learning their disease, learning their medicines, and understanding their diet. But look at what happens to the over 20 years of age. That is really when they learn self-management skills, not before they go to the adult services. So those of you who are focused on the adult services, please understand that they're not ready to self-manage the disease in the majority of the cases. Issues of reproduction focuses on them knowing if they're taking certain medications, particularly women, how can this affect the fetus? Or if they're males, we ask them and teach them their ability to have, to reproduce and have children. We talked about the transition index and the STARx questionnaire. I want to talk about the parent version and what we decided to do. So we learned that the kids like to learn from their parents, but we really never knew how much the parents know about their kids' illness. So what we've done with the transition parent version is half of the questions measure parents' knowledge about their child's condition, and the other half focuses on their parents' perception about their children being ready to go to the adult services. Okay, now we're going to show you some data, and I have to show off a little bit. This is Rebecca Ferris when she was 15 years of age. We had a quinceañera in Chapel Hill. This is Alex Ferris, 3 years younger than her, my youngest child, and he's 12 at the time. And these guys here are Rebecca's chambelanes. So they did a big dance, and it was a big 15th birthday party. Well, I want to show off my daughter. I want to point out the difference between her physique. A 15-year-old girl looks like a woman. Look at the 15-year-old guys. I mean, they still look like the young boys, right? But the reason to show that slide is to tell me, to mention to you that at age 15, readiness for transition skills just climb up. So if you don't have the manpower, or if you cannot start teaching patients at age 12, if you focus at age 15, you'll have some decent chance of teaching them on time. What else have we learned? We have learned that if you were diagnosed at an older age, you are better ready to transition, and you are better able to manage your condition. Whereas we have learned that if you were diagnosed at a younger age, it is more difficult for you to self-manage your disease, but you know more about your disease. So this red area, ability to self-manage the disease on this younger age diagnosis patient, make us wonder about the helicopter parents, or parents not willing to give up or more worried about their children, because they've always managed their children's diagnosis and treatment. What about differences by sex? We have learned that females understand more the importance of staying in school and to prepare so that they can have better health insurance, whereas males self-report that they're more comfortable making their own appointments and talking to their doctor by themselves. What about race? Our studies have shown that people who come from a non-minority group, from a Caucasian group, are more ready to transition compared to all other minorities. Asians are second to Caucasians in terms of transition readiness. We have also learned, and we test literacy and numeracy utilizing the newest vital signs. And this is a nice test to use. And we have learned that if you have low health literacy and low numeracy, you have less readiness for transition. Makes sense. A study that we published on burden of treatment, we've learned that pediatric patients with chronic kidney disease take more medication by far compared with other pediatric patients with other diagnoses. We've also learned that these patients with chronic kidney disease, compared to other diagnoses, like to use more pillbox and alarms and schedules. They mention that they need someone to remind them about their prescription more often. They say that they make a greater effort to understand what their health provider tells them. But most importantly, right here in the bottom line, they take more medicine and injections compared to other conditions. So our patients with CKD have a greater burden of treatment at home. They have more things to learn. But I also have learned that those patients who take more medications have more difficulty to get ready for transition, because more medications means less self-efficacy in managing their disease. I take this picture to remind me of these wonderful resilient patients that we have at times. And this young woman, she was it was difficult for her to learn to manage their disease. She wanted her mother to do everything. And I told her, find a way to make your life kind. Find a way that you like, something that you like when you look at your medicines instead of being negative. And she came up with this crown that says princess. So these little princess baskets, she keeps her medications in that basket. So she tells me that every time she has to take her medicine, something nice comes in front of her, and at least a more positive thought comes to her mind. I've also learned that youth that come from two-parent households found it easier to see their doctors by themselves. They felt like they knew more about their diagnosis, and they felt that it was going to be easier to transition to adult world. We also learned, no surprise, that if the family is more cohesive, it is going to be easier for patients to be ready for transition, and they seem to have more treatment adherence. Now, let me shift gears for a moment. So there has been some discussion within the transition field that if patients do more chores at home, they seem to be more ready to transition to adult services. And really nobody had studied that. A lot of that was opinion. So we decided to look at number of chores, frequency of chores, and readiness for transition. And we asked both the parent and the child about chores at home, i.e., doing the laundry, taking the trash out, folding laundry, things like that, helping to prepare food. And we have learned that the more chores they have, the better they are to transition to adult world. So one of the things that I always advise to parents is that you need to give your child chores at home and treat your child as much as possible as if your child had no chronic condition. And we show them this data. We also looked at those who are completely Medicaid and no other health insurance. And so we looked at 160 Medicaid recipients with chronic kidney disease, and we looked at what happens if they have low transition readiness. And in this particular population, these patients would use more emergency room and will have more non-adherence to treatment. Okay, let's shift gears, and we're going great on time. Again, our interventions that I'm going to discuss are featured in our webpage, med.unc.edu/transition, and they're free for everyone to use. Just send us an email if you're interested in using them, and we'll go back to let you use them. So let's talk about the first one, the medical passport. The medical passport is a provider and patient communication tool. It is also an education tool, and it fits in the wallet. And this is what it looks like. It looks like a driver's license, and one of the sides of the passport has the patient's picture and information about their date of birth, etc., and information for the emergency room if they go to the emergency room. This is my son, my oldest son, Ted Ferris. So we take this and give them to the patients after we've done the transition visit. We have to take a picture, and we do this in Publisher, First Publisher. So if you want this file, just send me an email, and I'll send it to you. You can change and put your logo here easily. I cannot tell you how many emergency room physicians have called us to thank us for this, because even though there's electronic health record systems, unfortunately not everybody has Epic or Cerner, so the systems don't talk to one another. So this is our poor man's electronic health record, right? The back of the passport looks like this. We put their diagnosis, their allergies, specialty phone numbers, and on the right side of the passport, we put their medication, how often do they take them, and why they take them. For example, MMF twice a day to keep your kidney happy. You get the idea. We have actually tested how much this passport has been used in the past, and we compared patients with chronic kidney disease to those with inflammatory bowel disease. Now, these two populations are very, very different. Patients with chronic kidney disease have more minorities. Patients with chronic kidney disease have more public insurance compared to patients with inflammatory bowel disease who have more private insurance and who are more of the Caucasian group. Though these populations are very different, there was no difference in usage of the passport. Everybody used it the same, not different. We did learn that the older the age, the more sustained passport use, and we also did learn that we have to revise the passports more often on patients with CKD compared to patients with GI conditions. We now have done the following. We don't change the passport, but every 6 to 12 months. We used to be so compulsive in the transplant group, changing the passport every month as they would come to their monthly visit and as the medications changed, particularly in the first 6 months post-transplant. That was too laborious, and we no longer do that. We do it every 6 to 12 months. They have their transition passports. And for those, a couple of times I've had some of those little criminals, I don't know, that's not the right word in English, but those little mischievous kids who have been stopped because of speeding, and the police has asked them for their IDs, and they cleverly pulled their transition passport before their license, and they have gotten away without a ticket, and they're giving warnings because the police notice that they have a chronic condition. So I can't measure that and publish on that, but I can share that anecdotically. So let's talk about some of the things we have learned. So we have learned that our patients have low literacy, and what I have done is I've implemented using plain words on all of our trainees that come to our clinic. They cannot speak in medical terms. They have to speak English to our patients. They have to be at eye level. And when the patients have questions, we have to answer them. And when I have done teaching in the bedside for the patient or the parent, I use the teach-back method. For example, I ask the patient, who is your best friend, and what are you going to tell your best friend that you learned today? Or I would ask the patient, what did you learn today that you didn't know before? And I do the same for the parent. This is the intensive care unit. We call it kidney notes. And while I'm talking to the patients, the students or residents are writing the points we're making for the day. Lastly, I'm going to talk to you about our kidney clues cards. And to me, this is one of the most rewarding interventions that we have used. And I love showing these to audiences. So I give patients in the inpatient service or in the outpatient service, we give them this little index card. And I visit with them and I tell them, tomorrow when I round, I want some questions. Or when you come to clinic, you come into the room and give me your questions for the day. Because I don't know about your practice, but in my practice, nobody ever has questions when I have done patient education. So here are the kidney clues, and this is giving the patients a voice. So this is a 15-year-old newly diagnosed patient with end-stage kidney disease. She was going to college and was going to get a basketball scholarship before all of this happened. So after our 3-hour session, or 2.5-hour session the day before, on educating her about end-stage and what it means, the changes in her life, she asked the essay, can I die from this? Can I still play sports? So what can I expect when I leave here? Will I be this way for the rest of my life? You know, even though we tell them this is the rest of your life, they're still asking this question. Her sibling asks, how can this affect our family and the rest of her life? Can she still play sports? Important to this patient's life. Will it get worse? Beautiful, right? Is it okay to be scared or nervous? So the things that we're learning by handing these cards to the patient that never ask those questions otherwise. I'm going to show you a parent question. Exactly what do you look for when her program doses change? Will we know if the infection from the donor is in the patient's name? Another 17-year-old female, very worried about steroids and side effects. Will I develop acne problems for sure? How long will I be on steroids? When will I be able to do math the way I used to? Such important things to them, and such things that we would not know otherwise. And I'm going to show you one last age group. This is 8-year-olds. Okay, these are 2 8-year-olds in the transplant patients. One, is my blood work good? Is my kidney doing good? Can my brother come to see me? And another 8-year-old boy, I beat someone on purpose. I will do better next time. That is their comment. So we're crazy about these kidney clues cards. We're learning so many things from patients, and I encourage you to try to use a system like this because it's so rewarding and so helpful. Let me move on to our technology-based and a pamphlet-based education. So we created the All You Need Is Love protocol. All You Need Is Love stands for Adherence and Longitudinal Life Skills for Youth under a Nurturing Educational Environment on Disease Intelligence, Self-Management, Lasting Outcomes, Visionary Empowerment Project. It's a long story how I came up with that name, but it has to do with what our patients need according to our transition coordinator. So this booklet is a low literacy teaching tool with patients and educators' input being tested for its effectiveness. And we have learned that it's effective and it's working. I won't have time to expand on this, but it's available in our website for free for everyone to use. Right now, we're working on another grant, and we're working on refining this app. It's called My Kidney Guru. And the Kidney Guru not only teaches patients how to interact with the medical team, but it's also going to teach patients what self-management is, how to be adherent, etc. The other technology-based intervention that we have used is Planet K app and Planet T1 Diabetes. And in this app, we have the avatar area where they can play some games and get some info core. We have the information core where the archivist teaches them about foods and drinks that they can use, what is kidney health and their medicine. And then another part talks about the more serious sodium, potassium, and phosphorus restrictions, and that's the health station. We have learned with this app that people who have used it improve on their transition and self-management scores, and their knowledge scores improve significantly after they have used this app. The other tool that I want to talk about, the other thing I want to talk about is billing for healthcare transition visits. I want you to know that if you do a healthcare transition visit, you can actually bill. You can bill for do an electronic health record consultation and telephone and internet consultation, or you can bill for visit in person with the physician or the health providers. And if you deploy surveys and interpret the surveys, such as the Transition Index or the STARx Questionnaire, you can actually bill for survey deployment. So while transition is important, it is good for research, it is good for patient care, it is also good to know that you can bill for those services. We went very quickly over the last 13 years of our activity. We have learned that transition and self-management is a process that should start in pediatrics but should continue in adult-focused settings, remembering the brain maturation that our patients undergo until their mid-20s and cognitive issues inherent to chronic kidney disease. We talked about transition and self-management that is related to patient, family, and the health system. It is an issue of quality improvement and is vital for patient safety and survival. I thank you for your time. I appreciate the opportunity to address you today, and I'm honored to answer your questions. Thank you.
All right, thank you so much, Dr. Díaz-González de Ferris. That was such an informative presentation, and we appreciate you taking your time to share your expertise. In just a moment here, I am going to turn it over to Paul to moderate our Q&A session, but before I do so, I'd just like to remind everyone that if you do have any questions for our presenter, please be sure to submit them using that chat feature. Again, it's located in the bottom left-hand corner of your screen. Also, during the Q&A session, I will have this poll up. So for those of you who are listening in a group, if you could please just complete this poll and let us know how many people are actually listening and participating in your group, that would be greatly appreciated. All right, and at this point, I'll turn it back over to Paul to moderate your questions.
Thank you, Deanna. Before we actually go into the Q&A from the audience, I did also want to just ask a quick question to Dr. Díaz-González de Ferris. Were there any unanticipated challenges or issues that came up when you had initially launched the program? And then also, what sort of new challenges do you anticipate facing with this next generation of, Gen Zers kind of maturing into this next phase?
So thank you for the question. The initial challenges were, how do we do this? When I started doing this program, I had contacted folks who have done this around the world. I visited a couple of programs in England and in Belgium and Holland, trying to understand how they do it. I visited a program in the U.S. I talked to experts. And really, nobody really knew how to do it at the time that I started. It was a field full of opinions. There was not a measurement tool that had been validated, because how do you know where somebody's progressing? And so the initial challenges for a particular program was to define and understand how to measure this process, and where do you intervene? What do you teach a 12-year-old, a 14-year-old, a 16-year-old, and an 18-year-old? And so no one knew at the time how to do it. So we, in many ways, were pioneers and are still learning from this field. The other challenge that we had was supporting the program. So how do you pay for a transition coordinator? And can your institution help you? What we did to begin with, we opened the program with grants. And in the first 3 years, we got a grant from the KB Reynolds Foundation And then after 2 years, I started to show our transplant administrators how important this was and what we were doing with our transplant patients. And then our transplant administrator, together with the pediatric hospital administrator, came together to fund the position of Christy Bickford. So from year 4 and forward, we had a funded transition coordinator position that was in budget of the hospital. Challenges have been to compensate patients for their time because they have taught us research, and so it's always hard to thank them for their time. But honestly, once they learn what we're doing, the parents are just crazy about what we're doing because we're not just only teaching their child, we're also teaching the parents. And so to go to the next question, so what's going to happen forward? One forward and present and past challenge was what happens to these patients when they go to the adult services? Who's taking care of them? How are they doing? Did our training and preparation make a difference on their outcome? And that's still a challenge because not everybody stays in the UNC system. So when they go to their communities, and we serve people from throughout the state, it's hard to find them. Even, for example, there's a study called CKID, chronic kidney disease in children. It's a longitudinal cohort of patients that have been followed for now 15 years. And even then, the organized NIH-funded longitudinal cohort is having challenges finding the adults, the young adults who are in that study. So that's a challenge. And the other challenge, or really more what we're going to do from here on for the next few years, is to develop the material to teach parents to let go, to be good parents. There are parenting scales. There are catastrophizing scales. There are parenting style scales that we are using to learn what kind of parents they are and to teach them how to let go based on the parent's parenting style and their catastrophizing. The word catastrophizing means anything's going to go wrong and it will go wrong. And if you cross the street, you're going to get run over by a car. Well, that's unreal and not real, not happening. But some parents have such degree of anxiety and catastrophizing that it immobilizes them. So that's what's happening next.
Great, thank you so much for that. We do have one person on in the audience who had asked, I'm interested in more information about the app. Did you develop it, and is it available for us to see?
Yes, yes, it is available for you to see. It's still, it was developed in partnership. It was my idea, but we developed it in partnership with an institute called the 3C Institute for Development. The 3C Institute is here in the Research Triangle Park, and so it's in Durham. I drive 8 miles to go to them. I spend my Mondays there working on this technology. It's a technology that cost us initially $250,000 to develop based on an NIH grant. And let me tell you, it's a great technology. It's the media that the kids like. They like video games. But one drawback is that it cost us $250,000 to develop what we have done. The kids play the games and conquer the games so fast that they come back and ask me, Dr. Ferris, what's the next module? Right? So it's a problem because while it is the media that they like, it runs out of favor in the sense that they already conquered the game. They got it. So we're trying to understand how to go about it. We are developing the Kidney Guru as an app that is not necessarily as expensive. It's web-based, that can be seen on a cell phone, on a smartphone, and that is more, it's less gamey. There's more avatar, and it's also going to be available. But that's an important question. And again, new does not necessarily mean better or best. So, yeah.
Great, thank you. And Deanna, do you know if there are any other questions that have come your way from the audience?
It looks like we haven't received any more questions.
I did have one additional question to ask, if I may, and this is actually in regards to peer mentoring. And I'm sure you have touched many, now adults who have, been part of the Passport and this, this transitions program. Do you ever ping them as far as, closing that feedback and seeing kind of how do we kind of re-engage that group or that cohort into, this next generation of, Generation Z, kids who are transitioning into that new phase of life?
Right. Talk about peer mentoring. Other commissions, not so much ours, but other commissions in other institutions like Brown University and Duke with Gary Maslow started a program, and actually in Chicago, Lurie Children, Parag Shah, they started a program of peer mentors and another program such as, particularly the Lurie Children in Chicago, a program of the adolescents working for Lurie Children to get a 6-week program where they would learn to do their CV and employment, etc. The peer mentoring groups are easier to conduct when the people live close and they are not so far apart compared to my patients. We serve patients from about 3 hours away from us. And so to have them do in-person coaching sessions is difficult. We have done coaching sessions on a transition weekend at Victory Junction Camp. So we take adolescents and young adults, 16 to 25-year-old patients of many conditions, not just CKD. They go for a transition weekend camp. And then we bring these mentors, people, for example, who are back on dialysis after losing their transplant for being bad citizens. And they will come and tell them, look, don't do what I did. This is what happens, right? It's always more remarkable when they see a peer that has experienced wrong things by doing the wrong choice. In another way of mentoring that we have experience with and that we no longer do is having a faith-based group. And it was a very interesting experience because Facebook, forgive me. See how much I do? So Facebook, we set up a Facebook group within our UNC Transition Program, and we had to stop it for 2 reasons. It took a lot of monitoring and woman power to be monitoring what the postings were. So they had to be kosher and good and no insults and no insensitive comments. So that was very time-consuming, and we just didn't have the opportunity to do so. But the good thing about a Facebook group is that when one of the patients was admitted to the hospital, a bunch of kids would come as a group to bring them flowers and to visit with them. So they established a small society, a small friendship, a small network. But the problem with at least our patients, chronic kidney disease, the condition is rare enough and our patients are far enough that it's difficult to do locally based support groups.
Great, thank you. Deanna, are there any other questions on your end?
Looks like we have no additional questions.
Okay. Well, we're about 5 minutes to the top of the hour, and if there are no other questions, I just want to again thank you, Dr. Maria Díaz-González de Ferris. I really appreciate your help and your time. And I think you have a tall order in hand. Maybe you can connect with some of the people at Fortnite to help with your challenging your apps and making them a little bit more challenging for the kids.
Right.
But,
right.
Yeah.
Thanks, everyone. Thank you for having me, and I really do hope that I was some help to you guys. And just send us an email. We're happy to talk. We're happy to help you get your program started. We can share our good experiences or challenges, and we are happy to play with you.
Well, thank you, everyone, and I'll hand it off to Deanna.
Thank you. On behalf of the Alliance, I'd just like to echo what Paul said and just extend a sincere thanks to Dr. Díaz-González de Ferris, as well as to you, Paul, for taking the time to join us today and for ultimately sharing your expertise on this topic. And to all of our participants, we'd also like to thank you for your time, and we wish you a wonderful rest of your day. Take care. Thank you.